TOSCIs as well. And what all I have included, the materials from the standard books, that is obviously there. Apart from that, I have taken the questions from the two videos which I shared to you. One is the TMH superficiality viva on this head and neck viva on CA tongue. One from that I have taken, and apart from that I have taken it from the this surgery academics by Professor Makhanlal and Professor Chintamani. Okay, these are the three things from which I have taken the all the viva questions. Most of them are covered. I don't think anything will be left behind after this. Okay, so we'll complete it in another 40-45 minutes. Let's start with it. We'll have that in that interactive session like we generally go. Okay, so generally, I'm sorry. Like if we get this history case of CA oral cavity, it might come as a short case also that describe the finding and how will you approach the case, and it can come as a long case also. So you have to be prepared for both of them. See, as I tell you every time, 90% it's gonna be CM squamous. Okay, so you cannot mess with CM squamous. You have to be 100% sure about CM squamous. When you get that confidence, that CM squamous, I'll do it. Then you move on to the next cases. So after that, what all you will do it? First will be thyroid, then will be CA oral cavity, and then will be CA larynx. This should be the order by which you should be preparing for a long case. Okay, so we'll be seeing for the CA tongue, how shall we go about? So we'll start with the routine thing. Routine thing. This much year old, male, female, came with complaints of generally what will be the presenting complaints? There will be a non-healing ulcer over the tongue. Now over here, you have to specify which part of tongue. Okay, lateral border of tongue or dorsum or ventral, and what all it's involving. Okay, this should be 6 months to 1 year, whatever history you are taking. Then you have to mention about the growth in size, that initially this was itna centimeter in size, which has grown to this much amount of size. See, there will be some instances where people say that initially the growth was size of a gram. Now it has it was a size of a pea, and now it has grown to a size of a lemon. But generally in our setup, what mostly I have seen in during my residency days, during the after residency days, and in all the vivas which I have undergone, you can mention it in centimeters. Like initially the growth was 1 into 1 centimeter, and now over the last 6 months it has progressed to the present size of 3 into 4 centimeter, or whatever growth you are telling. So you have to comment upon the size, that is the growth. Then you have to mention about whether there is any pain associated with it. Then you have to mention whether there is any bleeding or any pus which is coming from it. Then you have to mention about any other associated features like any dysphagia, or dinophagia, or any associated symptoms of malignancy. Prolonged cough is there, hemoptysis is there, and one very important thing which you have to mention is that is there any history of sharp tooth? Why? We will just see in a while. Okay. Now, apart from presenting complaint, you have to describe what is the history of present illness. Then you have to go about what is the past history like. Did he had anything in the past, any other complaints which he has? Then coming to the personal history, again it's very important. Why? Because dealing with the malignancy, you have to tell about smoking. You have to tell about alcohol intake. These two are main things. Okay. Last time also we saw what is the action when smoking and alcohol goes together. This is a very important viva question that they'll ask you. Acha, okay, Dr. Sahab, there are 2%, one who smokes, one who doesn't smoke. So what is the relative risk that a person who smokes has a higher in malignancy patient? So you have to mention that data which was quoted from Scott Brown itself, or any article, standard article, if you have read apart from it. I'll prefer Scott Brown. You should speak Scott Brown. That sir, this much is the relative risk that the person who smokes has more chances of developing cancer as compared to this person who doesn't smoke. Then second question will be, why you are taking history of alcohol. So you have to tell all those 5 points, that the alcohol has synergistic action. You remember this thing? The 5 points. Okay, that alcohol has the synergistic action. Then the byproduct of alcohol is acetaldehyde, which is toxic. It upregulates the certain enzymes. It decreases the DNA repair enzymes. So you have to remember those 5 points. Okay, without failure, you have to remember those 5 points. Okay, then comes family history. Okay, so you have to mention, sir, family history is nil significant. Or you can even use this line also, sir, there is no history of any cancer running in the family. And then again, as I always tell you, wait for it. When you know the answer, that this question is expected out of it. So after this, please wait for I'll say 5 seconds pause. Look at examiner. There might be a chance that he asks you, Acha, doctor, tell me what are the familial cancers you know about. So you should be ready with at least 3 answers. So can somebody take a try and tell me what are the familial cancers you know about? Revise it once.
Sir, medullary carcinoma.
Medullary carcinoma. Okay. Apart from that, any other familial? We saw something in the previous class on CA larynx.
Fanconi's anemia.
Fanconi's anemia.
Syndrome.
Great. We got it. Fanconi's anemia, Bloom syndrome, ataxia telangiectasia. And as Dr. said, medullary carcinoma of thyroid. Okay. So 3-4 you should be remembering. And all these things have their associated genes also. Okay. Last session also it was there. In this one also I have included a PDF. Please remember the gene, how they are inherited. That is also important. Okay. So after family history, has he taken any treatment from the till now? You have presented, and then when you will complete your history, you'll arrive to a specific diagnosis. Before examination, there might be a chance that examiner asks you that okay, so based on your observation, what do you think? What it is? Is it a benign swelling or it is a malignant swelling? So chances for a malignant swelling, you should know the positive points. What you have to say. That is any increase in the size, okay, and second is any induration associated with the swelling too, and third is any that non-healing ulcer which is there, and fourth is you have to take history of this pre-malignant lesion also. So what all you have to take, I'll just discuss in a while. There will be leukoplakia, there will be erythroleukoplakia, and there will be OMSS. Okay, so over here, all the PDFs are included. I'll just share with the important points with you. See, these are the points. These are the points of alcohol. Why alcohol and smoking together are harmful. You all remember it. Please go through them. These are important. They will be asked. Okay. So you should remember that alcohol acts as a solvent for dissolution of the carcinogens of the smoke which they are there. And second question will be, which will be covered in a while, that what all carcinogens are present in the smoking. Why do you say that smoking causes cancer? So as a final year PG undergoing exam, you shouldn't stop after saying nicotine. केवल nicotine बोलने के बाद रुकना नहीं है ना? You should speak at least 3-4 carcinogens at a stretch. Okay, we'll see along with it. Okay, so what all else you can have? See, this is a thing which you can quote. Okay, so please have a look over here, that the risk of oral cavity. What this is a very common viva question, that they'll say ki, acha, Dr. Sahab, there is a person who comes to you and he says ki, I stopped smoking 2 years ago. And how will you counsel him, that what are the percentages that he will have malignancy in future or not? So this is what you have to tell. Sir, the risk of oral cavity is reduced by 30% who have discontinued it up to 9 years, and by 50% for those who have discontinued more than 9 years. So please ratify this line. If once say 9 years tak 30% reduction in risk, and more than 9 years, you should know that it is risk is less than 50%. So this is the data which you have to answer. Okay. So moving ahead, this was the syndromic association or the familial malignancy which I was talking about. There will be Lee-Frommeni syndrome, Fanconi's anemia, Bloom syndrome, ataxia, telangiectasia. Okay, so these are basically the malignancies which run in the family. Okay, moving here. Now over here there is a little bit change in the latest AGCC. What they have done is, does anybody know the answer? What is the change which latest AGCC have done in this staging?
So depth of invasion is...
Yeah, great. Okay, so you have to include the depth of invasion in this. Okay, so I'll just mention it for you. Depth of invasion, and this is tumor greatest dimension. So basically for T1, this is less than 2 centimeter and this is less than 5 mm. Remember, this is centimeter, this is mm. This is depth of invasion. Please remember the difference between depth of invasion and tumor's greatest dimension, tumor thickness. Then goes T2. This should be less than 2. So यहाँ पे इसके corresponding is 5 to 10 mm. And when this is 2 to 4 centimeter, this is less than 10 mm. Almost same. Then comes T3. This increases more than 4 centimeter and this goes more than 10 mm. And for T4, you can refer this. Okay, what they have mentioned. Okay, so moving here. Next question which you should cover is, I'll just share with you guys. See, these are the another, similarly this familial cancers have been repeated twice. Okay, so please go through them, including Lynch syndrome. Please remember what genes they code, like what genes are associated with them. Bloom syndrome, xeroderma pigmentosa, okay, ataxia telangiectasia, Lee-Frommeni syndrome. Okay, so it's always better to know only two things: how they are inherited, one, and what gene is associated with this. Okay, in the pre-malignant lesions, there will be associated chance that supposedly like Mr. X has leukoplakia and Mr. Y has erythroleukoplakia. So what are the chances of it converting into malignancy? So the chances are, you should remember it. This is leukoplakia, 2.9%. Okay, this is a very common question that when you will say that, sir, the patient on the same thing you can repeat in the history also, and the same thing you can go about in the examination also. When you say in examination of oral cavity, sir, there is no leukoplakia, always mention it. And normally what we say is, sir, the oral cavity, oral hygiene is fair, oral hygiene is good, or if you find any nicotine stains, you mention about it. So it's always better you can say, sir, there are no leukoplakia or no erythroleukoplakia, and then he'll ask you, what is leukoplakia, what is erythroleukoplakia, what are the percentages that this leukoplakia will turn into malignancy. So you should be ready with these answers. Okay, and if you don't know it, then keep saying, sir, it's fine, it's good. But believe me, the more you speak with the examiner, the more you discuss, there are more chances of you passing the exam. Again, I repeat this thing in almost every class. Those 3 hours cannot decide how much knowledge you have. They cannot decide what you have done in the last 3 years. But it is your duty to tell the examiner, yes, sir, I know this thing. Please ask me. I have to tell you, and please give me more than 50% marks. I have to pass this bloody exam. Okay, so you have to tell the examiner. You have to make those points. This art, giving a viva, is an art. Believe me, in your 300 marks of your practicals, 100 marks will be OSCE. Okay, so that is not in your hand, and for that you have to obviously work hard. There's no other way out. And another 200 marks, that is mostly of that viva session is there. That is more of an art. I'll say 40% is your memory, hard work, kismat, and 60% is how you present yourself. If you will speak such words जिसका आपको detail नहीं पता होगा, so you will dig your own grave. Like supposedly, if I don't know anything about leukoplakia, how to manage it, what is pathophysiology behind it, and I say, sir, there is no leukoplakia, and he asks me about leukoplakia, so I'll be caught in a fix. I'll get less marks. So that is the thing. Please read about those things which you are about to utter in your examination words. Okay. Second, if erythroleukoplakia, it has a higher percentage. That's 13 to 50%. Okay. Please remember these both of the things. Both are important. Okay. Now coming to another very important of the Viva question. What are the 5S of oral cancer? Like I still remember my case during my Viva. This was not in the main exam Viva. This was in a pre-exam hospital institution Viva. We had operated a patient. My faculty had operated basically a CA tongue in a 34-year-old female. Okay. The first question which was asked to me was, yes, Tiwari, tell me, she is a female. What do you say? Why did she get cancer? Okay. So this is how you have to be proactive and expecting what questions can be asked. So that lady was not smoking. That lady was not using alcohol. So what could have been a main etiology in such a patient?
Sharp tooth.
Sharp tooth. Great. Okay. So in case if you get a patient like this and who is not a smoker, not an alcoholic, be ready to get this answer. This will be asked for you. Okay? What do you think? Why did she happen to get this disease? So be ready with this type of thing. So what other S are there associated with this thing? Apart from this, are this smoking, spirit, syphilis, spices, sharp or septic teeth. Okay. So moving ahead, apart from this, why is this important? Over here, this is repeat of CA larynx. The same chart was there in CA larynx also. The carcinogens in smoking belong to multiple classes, including polycyclic aromatic hydrocarbons, nitrosamines, aromatic amines, aldehydes, organic hydrocarbons, metals. These are apart from your nicotine. Okay. So first speak nicotine and supplemented by nicotine in the same breath, in the same sentence, please mention at least 2 to 3 of these other smaller items so that the examiner knows, yes, this guy has read about smoking. And if you are interested, this is the pathway of cancer which is associated. This is basically more of a theoretical point of view that how cancer is caused. Okay. Moving ahead, this is a flow chart basically for theoretical purposes, not for practical. Okay, no need for reading it again and again. They have repeated again that what are the carcinogens again in the smoking available over there. Okay, so please remember it. It shouldn't be missed. Okay, so moving to another favorite Viva question. What is the etiology of CA oral cavity? So we all remember first will be tobacco, second will be alcohol. As you say alcohol, the question will come that what is the effect of alcohol when taken along with tobacco, and the word which you have to speak, DNB is looking for these keywords: synergistic action. You will keep beating around the bush that it has the action is potentiated, the action increases, the action is plus. No. Synergistic is the word that you have to use, that this has a synergistic action when taken along with tobacco. And apart from that, these 5 points you have to remember. Okay, infection we all know, HPV, HIV, HSV, nutritional factors, dental factor is an important thing, genetic and immunological predisposition. We have seen the problems that can be associated in the familial malignancy. Okay, now second question again over here, ECOG and Karnofsky. ECOG and Karnofsky. These both are the performance scales. Okay? Please remember any one in detail. Full form of ECOG is required of you to know, and you should know at least one. This is the ECOG 0 to 5 and Karnofsky is till 100. Anyone that you follow in your institution, please say that, but you should know the name of the other one. Where you have to use this, when you will start with your examination, general condition of the patient, whatever you feel, is it fair, is it not fair, and just below it mention, sir, ECOG is 1 or ECOG is 2, whatever you want, and just wait for the examiner to ask, doctor, what is ECOG? Please be ready with this answer, sir. ECOG is Eastern Cooperative Oncology Group. This itself is in a question. Okay? This itself is a individual OSCE question for 1 mark. Then you can tell him, sir, 0, 1, 2, 3, 4, and 5, and you'll be ready that why do we do this ECOG or Karnofsky? So you have to tell him, sir, this is basically a performance scale. So to measure what are the before the treatment and after the treatment is given to the patient. That is after the surgery, after the chemotherapy or radiotherapy, whatever has been decided as the treatment guidelines, what has been the changes in the like performance of the patient. One, second, for the medical legal purposes as well. So any one of them you have to remember it fully. Whatever you are including it in your exam, it's not necessary that you include ECOG or Karnofsky. Anyone you can include, but please remember both of them. At least name are very important. ECOG ka 0 to 5 you cannot forget. Okay, moving ahead. Okay. Second question is, when you'll go about tongue, there are chances that they might go into the anatomy of tongue. So anatomy of tongue, mein 3-4 questions can come. One will be your muscles of tongue. Second will be the questions right from your anatomy days, nerve supply. Okay. And third will be images question. Images. What are the images of ye? So in the end of this PDF, I have included the images of all the major muscles of the tongue. Please go through it. It will be important and it will come in handy while you will revising it. Okay. So basically, can somebody tell me what is the safety muscle of the tongue?
Genioglossus.
Genioglossus. Okay. Please remember. Parle G, Junior G, whatever you want. This is the safety muscle. Why is it safety muscle? Because it helps it to be in the place, to not to fall backwards. Okay, and the fan shape glossus, palatoglossus, whereas these will form a part of the extrinsic group of muscles. And in intrinsic, they have divided into longitudinal, which are superior and inferior, and transverse and vertical. This is naam ke liye hai, nothing important in this. This you have to remember because iska question is here. Nerve supply. All are supplied by hypoglossal nerve except palatoglossus. Okay, which is supplied by the vagus branch. Okay, so somehow you have to ratify this thing that these are the mnemonic. How I remembered it. I'm very poor in anatomy, so I need something to remember it. This is how I remembered. GH means girls hostel. GH. Normally what happens, everybody puts some sort of style in front of the girls hostel so that somebody is palat. Okay, so GH style, and palat is always like, it means that reversing. So everywhere it will be hypoglossal except palat, which is by vagus nerve. Please remember it. Okay, and how is the supply different? Anterior to, like, see, if they ask you that how is the nerve supply of the tongue, so you have to mention it this way, sir. Anterior 2/3 ka general sensation lingual nerve and taste sensation by so and so. Posterior 1/3 and posterior most. So this is how you have to approach this question for like ideal way, I'll suppose. And else, if you don't want to go like this, then you can, like, you have to take names of everything in your own way. Okay. Over here, see, this is the question which I was talking about, that leukoplakia has 1 silicate 2.9% annual malignant transformation rate. So that's why leukoplakia is important. So this question can also come in when you will start, when the examiner will ask you that, Doctor, how will you manage the case? Okay, so when this question comes, how will you manage the case? So you have to start with investigation. Okay, investigation and followed by like whatever definitive management you will decide. So in investigation, what all things you have to tell, sir? You have to mention about examination under anesthesia. One. Second, biopsy if you want to take under anesthesia, that's okay. If you want to take under like normally in the OPD procedure, that's also okay. Third will be radiological investigation. Normally, lateral border of tongue, buccal mucosa, MRI is the management of this radiological investigation of choice. In case MRI is not available, then you'll go for CT, followed by which you'll be making your what is the staging of this? Such staging you have to remember. Please don't forget. Like in the last class, we told the supraglottis, glottis, and subglottis. Tino ka you have to remember it separately. It shouldn't be like I have learned only CA glottis, so I'll not know about supraglottis or subglottis. He will ask you all three if he's a khadus one. Okay. Same goes for the tongue. Please don't forget it. T1 to T4 it is important. Okay, so over here, what are the important points? I'll just enumerate. Okay, over here, 3 things you have to mention, which is important. One will be this. First point, that lymphatic drainage at the lateral border of the tongue is to the ipsilateral cervical nodes. One, and second, why bilateral neck dissection is required because drainage of the midline, tip and base of tongue occurs bilaterally. So if in case the size of the tumor is more, you will require bilateral neck dissection. And third, over here only I like to take it. This was a very favorite theory question. Long answer. Management of N0 neck in oral CA. Okay, believe me, this will not leave your picha in Viva also. Okay, so for this, I've sent you that article. Please go through it, DeCruz et al. It is important. What they have done is basically, initially what was being followed was that in case there are no nodes in neck, so generally they used to resect the tumor itself and then come back. But it was seen that this thing has been recurring again and again. So what this Dr. DeCruz sir had done was, he divided the patients into two groups. One patient in which like all were having N0 neck. Okay, so there was one group which was like apart from surgery ke alawa, elective neck dissection was also done for the patient. And second group was kept under follow-up. Regular ultrasound follow-up was done for those patients. And when neck nodes came positive, so उनका तब therapeutic neck dissection was done. So they found that mortality was much higher in the therapeutic neck dissection group, जिनको बार-बार बाद में कर रहे थे, and like follow-up was very survivability was poor. So that's why this thing was formulated. This data was collected, and this thing was dropped in between itself, before the whole study was completed. That in N0 neck also, whether there are nodes are positive or not positive, you have to take neck dissection for the patient in CA tongue. Okay, so that has become a dictum nowadays. Okay, but in case something else is happening in your institution, you can stick to that. Sir, book says this, but we are following this in our institution. Okay, so coming over here, second point is, okay, we have seen this thing, not an issue. Okay, so moving ahead, here also three things you have to remember, that while mentioned it, the first one is the compartmental approach. What is the compartmental approach? Basically, that what all you have to preserve the tip of the tongue, one, because it helps in maximizing the post-op function, one. Second, types of glossectomy. And what flap will you use to reconstruct? These two questions you should be like, these are expected questions. Okay, so these are the name of flaps which are given. Okay, so you can answer anything, that sir, free flap reconstruction by either radial free forearm flap or ALT they can use. So any one of them you can answer. Okay, so both are given in your answer. हाँ बताइए.
So what is compartmental resections?
No, basically what they are saying is कि resection of tumors using a compartmental approach as a see, that has nothing specific to do with the CA tongue per se. That has nothing to do with CA tongue per se. They are saying that this is a general oncological principle, that you all remember that in places they take 1 cent, like what in our institute they used to follow was to take 1 centimeter margin along the whole mass which was there. Okay, and like the surgeon used to take 1 centimeter clear margin to take it out as a whole. Okay, so these are certain oncological principles, but this has nothing to do like specifically with the CA tongue. Okay.
Okay, sir.
Okay, moving ahead. Over here, three things you have, two more things: neck dissections and radiotherapy. So what you have to know over here is that they will ask you, when you will do neck dissection, bilateral neck dissection should be considered in tumor that extend to or beyond the midline. So this should be one statement. And second, neck dissection is compulsory, whether N0 is there or N1 is there. Ipsilateral to hoga hi hoga. Bilateral kab karna hai? When bilateral neck dissection will be done, when the tumors are extending beyond the midline. So you have to remember this word, midline. Okay, and for this you have to be thorough with your drainage of the cervical lymph nodes also. The question can very well go from So tell me what are the 1A lymph node, 1B lymph node, 2A, 2, 3B, 3, 4, all this level of lymph nodes. So you should be ready with this question. When you will do neck dissection, when unilateral, when bilateral. Okay, so moving ahead, ये हो गया flap वाला question is you are ready with ALT and free forearm flap. Okay, and see, this is where they have mentioned in short. De Cruz et al. Please go through these data. This they have mentioned in short, basically, that De Cruz et al. I'm reading it from here. Okay, there were around 500 patients divided into two groups. One was the elective surgery group, one was the therapeutic surgery group. And basically, the group where elective neck dissection was done, they had an improved rate of overall survival and reduced mortality as compared to the other group. So that's what they are trying to mention over here. So this is an important paper. Please go through it. Okay. Second will be, when will you do radiotherapy? Next question will be, when you will start mentioning about other experts, what will be when you will give radiotherapy to the patient? So these are the answer which you have to mention. Sir, when the tumor has positive margins, what you will do, you will resect the tumor with 1 centimeter wide margin and send it for HPE. When the report comes back, if there are positive margins or there are multiple cervical nodes, or extracapsular spread, and stage 3 and 4, means basically advanced stage disease है, perineural spread है, and thickness is more than 9 to 10 mm. So these are indication for your post-operative radiotherapy. Okay, so what can come is, how this question can be framed is, they can give you an image of say a tongue with a ulcerative lesion on the tongue itself, and they might ask you the questions. One of them which can be, what are the indications for neck dissection? 1, what are the indications for bilateral neck dissection? 2, and what are the indications for PORT? So the problem is, if somebody has not read what is PORT, so he'll get that full form itself, what is PORT. So these are the 4 points you have to mention if it comes for 1 or 2 marks. That it should be the positive margins, extracapsular spread, advanced stage disease, perineural spread, and the tumor more than 9 to 10 mm. Okay, so over here, next will be, see, this is Slaughter et al. Please remember it. It will always come, it will always haunt you whenever you study about CA oral cavity or any CA of the aerodigestive tract. Indications of neck section CA, one will be, I'll not mention about the theoretical. Similar unilateral, you have to say that in all cases we will do unilateral neck dissection of the side, and in case the tumor growth is reaching midline, so it will be bilateral neck dissection will be done. Okay, so this is data has been done. Okay, this mentioned, then comes this data. This has already been done. Okay, indication of radiotherapy in CA tongue. Okay, so this is the same thing like mentioned again in a paragraph. Okay, please don't forget, these 2 questions are like asked many times: neck dissection and radiotherapy. When will you give? How will you give? Okay, how will you give? You have to remember about brachytherapy. Okay. There's something called about brachytherapy. I'll share the photograph and PDFs of brachytherapy along. Okay, so this you have to read too. Okay. Now, there's something called as visor approach and lingual release. Now, during the surgery of surgery of your CA tongue, there is a named approach over here. What they use? So, what they use? 2 names you will remember. One will be visor approach, and along with lingual release, they sometimes people perform this mandibulotomy also to gain the surgical access. Okay. Now, यहाँ पे जो what questions can be come is, what is visor approach? This is given. And second question, as you will say that, sir, mandibulotomy, they'll ask you, where will you perform the mandibulotomy? So this is the point you have to remember. that the osteotomy should be conducted anterior to the mental foramen. This is the good anatomical landmark. So to preserve the labial sensation. Okay, and what is the preferred site for osteotomy? This is in the between the lateral incisor and the canine. Okay, this details about the mandible per se will deal in the osteology. All details about mandible, all details about maxilla and sphenoid bone. These three are the main bones that we have to study. Apart from temporal bone, that is I assume that everybody is treating it as God. Okay, so in osteology section we'll deal about the details of mandible, what are all the classifications associated with mandible and maxilla. So I'll not touch those things here, but this is a question that can come to you invariably, that where all are the osteotomies performed. Okay, apart from that, what questions are there is osteotomy से related two questions are more. ये तो हो गया mandibulotomy. Second will be in maxillectomy there will be total maxillectomy, there will be medial maxillectomy. So where all the osteotomy cuts are given, that is one question in itself. This will cover when we'll be doing maxilla and mandible. Third will be during rhinoplasty, where all we give the osteotomy. So these three things you have to remember. Okay. Now coming to another questions, types of neck dissection. Yeah, definitely there are around 5 to 7 neck dissections which we'll see about. Okay, last one we saw about one, that is the Gluck Sorensen incision. Okay, and remaining one we'll see in a slowly stepwise pattern, not to just mess about with them. Okay, and what do you remove in each type of neck dissection? And basically what do we do is, just to go through here, all the game is like rotating about these three. Right? We are removing IGV, we are removing SCM, we are removing SN. So what happens? Basically, most of the lymph nodes are around IJV. Most of the lymph nodes, they are around the IJV. So therefore, while removing the IJV, we get a good access to all the lymph nodes. Okay, and lymph nodes generally they remain stuck with the IJV, so that's why we have to remove it. And by this SAN, basically it divides the level 2A lymph node from the 2B lymph node. So therefore, to clear 2B, SAN has to be removed, and SCM, that is the sternocleidomastoid, definitely it has to be removed to gain good exposure for neck dissection. Okay, so breaking the monotony, this is a procedure that can come to you. This is your fees. Okay, how you can go about it? See, you can see this colored secretion which are retained in the supraglottic region. Okay, so this is basically full form of fees is fiber optic endoscopic evolution of swallowing. Okay, and there is one modification of it by the name of feast. So what they have done is, everything remains same. This is flexible, endoscopic, evaluation of swallowing with sensory testing. Okay, so these are certain more details about fees, and this is a link for the difference between fees and this study. Okay, so again, these images are from KenHub itself. Okay, the images of muscles of tongue that I have taken from KenHub. These are the details about the anatomical thing. Nothing much to reach. You have to know about the muscles 1, 2, 3, 4. ये वाला origin you don't need to remember. But for genioglossus and hyoglossus, please try to remember it at least. Nerve supply you should not forget, and origin and insertion of at least genioglossus and hyoglossus, try to remember it. This can come being one of those major muscles of your tongue musculature. they can, like, it can be asked. Okay, so please keep in your mind. Images I have included in the last. These images are at the last. Okay, now coming to this one more Viva question, that this can be a very good question, that while evaluation, how will you evaluate the patient further? So you have to tell, one, sir, I will like to examine under anesthesia, one, then be ready for answer that why are you taking the patient to examine, giving anesthesia just for examination? So you have to answer that thing accordingly. That, sir, I want to map the growth. I want to see whether there is any extension. What is the margins of the tumor? One. Second thing is imaging. Imaging, mein what you can say? You can say both CT as well as MR. But MR is the investigation of choice for growth of lateral border of tongue. One, buccal mucosa. And apart from that, what you should say, that why you are doing it, sir, we know we are doing it to define the extent, to define, see whether there is any distant mets or not, and to see any perineural invasion and depth of invasion. Okay. This is the difference between tumor thickness and depth of invasion. What is the difference? That DOI is basically when there is a horizontal line which is drawn from ulcer and the normal mucosa at the level of basement membrane. So this difference is the depth of invasion, whereas tumor thickness is tumor edge से लेकर के deepest point of infiltration. See, I would tell you that this is one of the very confusing things. This, in literature, I could not find any exact difference, but this difference was quoted in the this TMH Viva, which I have shared to you. Okay, so that this I've taken from this Viva itself. This answer, supposedly the examiner was okay with it. But as far as our standard books go, I could not find a very good and satisfying answer between both of them. Okay. So another thing, that why do you want to do an MRI basically? So you had what approach you are planning, and second thing is reconstruction. Okay, so reconstruction, you should be ready with your two answers, that it can be reconstructed with the radial forearm, free forearm flap, and the anterolateral ALT thigh flap also. Okay. Then visor approach you have seen. Okay. So basically speaking, you should remember that primary closure can be done till the growth of 1 centimeter. Okay. Whereas free radial forearm flap anterolateral thigh flap, fibula flap, this you will do till if you are doing hemiglossectomy. But if you are doing total glossectomy, so PMMC should be your which you can use. Okay. Okay. So two more questions. When tracheostomy is required in these type of patients, when there is involvement of genioglossus. Okay. So we all know that this is the safety muscle of tongue. So in case if we excise it, we remove it, more mass, more chunk of it, we remove it, there are chances that there will be difficulty in respiration, and hence we have to go for a elective tracheostomy, and when there is an extensive resection. Second question is, when you want to do examination under anesthesia, these are the points. For basically when the patient is uncooperative, and when you want to do a 3D mapping for the patient, and for posterior extent. Okay. So please remember about genioglossus, that is important. Let's see these muscles once. Okay. So these are the muscles. Please remember about, my bet always will be on the biggest one. So please go G and H, both you have to remember. Baki ek bar just have a superficial look. Okay. So this is the genioglossus muscle. See how this question can be framed. This can be given as an image based question, and they can mark it as X, mark it as Y. Okay. And you will be asked to identify what is X, which nerve supplies X, or which nerve supplies Y. So that's why this question can come in multiple amount of ways. Please mark what is the safety muscle of the tongue. Okay. Similarly, after genioglossus, see, this is one more image of the genioglossus. You can see the fan-shaped insertion and origin. Over here, this is the hyoglossus muscle in this section. Okay. And the next one, this is the palatoglossus muscle. This is your palatoglossus, the green one. One more image of the hyoglossus. We'll see the same in the during submandibular gland as well. Okay, so examination basically 2-3 things you have to mention. Baki to it's all same as the CA oral cavity, CA larynx as we had seen. So you'll start with the general cavity, general condition, fair, your performance scale you should mention. And if it is coming as a long case, please mention about BP, pulse, SpO2, temperature, no pedal edema, lymphadenopathy, clubbing pedal, वो सब कुछ बोलना है उसमें, ठीक है? BP, if you are speaking about BP, please note that there should be a sphygmomanometer around you. Please don't get caught by this thing that you say sir BP is 120 by 80, but there is no BP apparatus around you. Okay, तो ये गड्ढा नहीं पड़ना चाहिए. And in long case, you can just say per abdomen, respiratory, CVS, CNS within normal limit. And coming to local examination, you can start with oral cavity. Local examination, you'll start with oral cavity. The starting option will be the mouth opening. This is how you can start. So mouth opening denotes that whether there is trismus or not, whether there is involvement of muscles of mastication or not. So that you have to mention whether the mouth opening is normal. Then comes the oral hygiene. Okay, so in oral hygiene, you can talk about the nicotine patches, you can talk about leukoplakia, erythroplakia, any lichen planus, any oral submucous fibrosis, that is important. Okay, then coming after oral hygiene, you can talk about gums, teeth, gingiva. So here teeth become important because you can comment whether there is any sharp teeth or not. This is a question. Then comes your anterior 2/3 of the tongue. So here, how you have to mention about the growth? Sir, there is 2 into 2 centimeter ulceroproliferative growth, left lateral border. Okay, whether it is crossing midline or not, that you have to mention. Then whether alveolus is involved or not, this you have to mention. Okay, and ventral surface में कहाँ तक गई है? Why you are mentioning these things? So as you should be able to arrive at a what all management you have to go about. Baki apart from this, please mention the remaining things, the hard palate, the RMT, all these things you have to mention. Okay, then oropharynx, no fun in telling. You have to mention about base of tongue, about the tonsils, about the uvula, okay, and the posterior pharyngeal wall. Then please don't forget to mention about neck. This is, I'll repeat, this is a mistake which we make. He will ask you that you have forgotten something to examine. So you have to mention, sir, neck also we have to examine. And what will you examine in the neck? You have to see for any swelling or any lymph nodes. Swelling or any lymph nodes. And same things you will say in palpation. Okay, these are the findings of inspection are confirmed on palpation. The growth which you have, which is there on the left lateral border of the tongue, whether it is hard, whether there is indurated, can you get around the swelling or not? This is the thing which you have to tell. Get around the swelling. You can move 360 degree around the swelling or not. And then when you go in the neck, you have to mention about the cervical lymphadenopathy. Okay, and hopefully if you reach till here, then all the things, all the viva can again start on your management. Basically, how will you investigate him further, how will you manage him further, and then after management, the third thing is rehabilitation. Okay, so how will you investigate him further? You have to frame your answer in these three things. How will you investigate him, how will you manage him, and how will you rehab him? Okay, so this was all that I had to tell you in this. Please go through those 2 videos which I have shared. Ideas will get little bit more refined, I'll say. Okay, this is what all I have taken and put it in a very I'll say simple and user friendly language which I could do it. Okay, and just go through them. You'll find the same questions, the same answers with a pinch of salt over it, I'll say. Okay, apart from that, please go through the paper on this paper of De Cruz et al. That is important. Please go through the chapter of oral cavity in Scott Brown at least once. It will help you out. If you can corroborate it again with Sterling Marin, that is very good. Else एक जगह से पढ़ लेंगे तो that will be okay. And type of glossectomy I'll share in a while. What are the type of glossectomies? I have a small 2 page का छोटा सा handwritten note है. It will help you out. Okay. So till now, any confusion, anything, any positive or any negative comment, please let me know.
Sir, this depth of invasion only by MRI we can evaluate.
Yes.
So clinically
Yes.
we can't.
Clinically तो नहीं बता सकते ना clinically नहीं बोल सकते. Clinically you can only say whether the growth is crossing midline or not. This is the only thing which you can say clinically. Apart from that, you need radiological investigation.
Okay, sir. So after presenting the case, so usually they don't ask the staging, consa stage as.
See, they shouldn't ask you because you don't have a MR report in your hand. So how will you know whether the depth of invasion is 5 mm or 10 mm? But just to screw you, they'll ask you tell what if what if T1, T2, T3 and T4. Okay, so you don't have to say, sir, this is like this is exactly stage 3 or 4, but you should mention, you should be remembering, sir, this is T1, T2, T3 or T4. Like, I'll just give you an example. Just a minute. ठीक है. अब like see, if you see, they'll give you a hint. Like if you get a patient who has a massive proliferative growth, okay, which is evident कि ये 4-5 सेंटीमीटर से ज्यादा है, ठीक है, so definitely you will be ready that sir, this is at least more than T3. You don't require कि भैया मतलब अगर 4 सेंटीमीटर है तो it looks like ना clinically you can say that this will be depth of invasion will be more. Clinically you are seeing that UPG lesion, it is involving till the alveolus. Okay, so this is how you can say कि sir this is the dimension which I can see, but I will need a MR imaging to comment exactly upon the depth of invasion, following which the staging will be mentioned. Okay, so you should be ready with this thing. Basically this is yeah, okay, you should be, this is all you should remember. Baki it's up to your kismat and what the examiner has in his mind. If he's there to just make problems more and more for you, then you can't do anything. But if you tell these things, definitely you will pass, that is sure. Baki फिर it's in God's hand only.
Thank you, sir.
Okay, anything else from anybody? Okay, if nothing, then we'll call it a day. है ना? चलो revise it once. It is a confusing topic, I'll say. Okay, and for the next session we'll meet on, just a minute, I'll just check अगला session कौन सा है. Yeah, next one will be 3rd Jan, 7th Jan. Okay, yeah, on 7th of January, the important scientists and instruments. Okay, so till that time, till now I have shared around 4 scientists, 4-5 scientists ही share किए हैं, है ना? So till that time I'll share all the entire list of 15-20 scientists slowly, and that day we'll revise them in toto. And in instruments, I'll share you the PDF of instruments. Go through them at your own pace. I'll share we'll discuss the important ones, like basically what all retractors are used. Okay, all types of retractor. Then second will be the types of stapes surgery में जो use करते हैं, है ना? So these important things we'll discuss in the class. Laryngoscope, esophagoscope, these we'll discuss. बाकी जो routine वाला है, I'll share the PDF. Please go through them at your own sweet pace, but go through them once or twice. Go through them. And third thing is FES instrument. So अगर अभी भी still your people are in your institute itself working in the hospital, please go in your OT and just ये FES के instruments एक बार देख लेना, because those are the instruments which cause confusion. What is the giraffe forceps, what is peanut forceps, okay, optical forceps कौन सा है, so that you should see in front of your once in your own eyes. PDF में that thing is never cleared. Okay, so this was one of my drawbacks which I felt during my exams. Okay, so just if in case it's possible, please look once at your test instruments. That will be okay. Else, we'll go revise all the important things on 7th. Okay, 7th, yeah. Tomorrow, actually, again, this monthly duty is tomorrow. So that's why the 3rd January class I had to prepone it yesterday. I didn't want to spoil the Saturday for everyone. Okay, so we'll meet on 7th. Till that time, every day we'll discuss these important questions and we'll increase the speed. Okay, now till now we're around 10, 12 questions each already. We'll increase them more and we'll start repeating it again and again so that it moves ahead in front of your eyes. Revise it and don't forget it. Okay, chalo. Anything else from your side? If nothing, please feel free to drop me a message anytime. Anything is required. Still about time is left in the exam. You will get time for revision. You'll get time for mock OSCEs. Don't worry, but keep on studying. And now start increasing your time for studies. अभी तक जो आधा एक घंटा चल रहा था, please increase it up to 2 hours daily, है ना? And believe me, COMs commerce should form major chunk of that. बाकी चीजें उसके अलावा है. ठीक है, चलो, all the best. Good night. Bye.